Bismillahirrahmanirrahim. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. I am Dr. Mudassir Shahbaz, Associate Professor at Sahara Medical College, Narwal. And as we were discussing about the clinicals of the lower limb, and in the previous lecture we have discussed about the clinicals and why we need to know these clinicals. Now today we are going to discuss about the further clinicals. The first is the psoas abscess. Abscess means there will be some infection in the region of psoas muscle, where the psoas muscle will be having origination from the abdomen. There will be pus forming. Pus due to the infection of bacteria, and then it is attacked by the neutrophils and macrophages, and that is converted into the pus. So, psoas abscess. So, before we read this page about the psoas abscess, in my opinion, we should have a look on the fascial lining of the abdominal wall. Abdominal wall, here you can see, here is the origin of muscle, that is the psoas, and here is the muscle, iliacus. So when both combine, they form the iliopsoas, and which is inserted over the lacet trochanteric. And here we see that the psoas is having origin from the transverse processes of the lumbar vertebra, and the last one, the 12th vertebra, is the origin of the psoas, major muscle. So fascia is lining all over the body, so where it will be lining the diaphragm, it will be called as diaphragmatic fascia. And on the anterior abdominal wall, when this muscle transversus abdominis cover the anterior abdominal wall, then it will be called as the fascia transversalis. And when this fascia comes over this muscle, which is quadratus lumborum muscle, here, when it covers it, it is named as quadratus lumborum fascia. And then when it covers the psoas, then is the psoas fascia. Down, when it comes over the iliacus muscle, it will be named as fascia iliaca. So the important thing is that here is the arcuate line, the facial attachment of the facial lining, and the median arcuate ligament. Medial arcuate ligament, where it is over the psoas, then is the lateral arcuate ligament, where is the over the quadratus lumborum attached at the upper end. So this all will be covered by the fascia. So whatever the process, disease process, pus forming occur, it lies behind this fascia. And obviously when it is lying behind this fascia, it will travel under this fascia and will move into the lower limb below the inguinal ligament under this fascia. So before you understand the psoas abscessus formation location, the normal attachment of the fascia and the muscle attachment of the iliopsoas is very important to know. So then we come to psoas abscess. So it can occur associated with tuberculosis of the vertebral column, or secondary to the regional enteritis of the ileum, that is the Crohn disease. So in this way, the the abscess can form in this region. When the abscess is between the psoas and its fascial lining, it travels to the inguinal ligament and proximal region of thigh. There will be severe pain then to the hip, thigh, or knee. Why? Because the pus is lying behind the iliopsoas fascia and it travels in this way and comes to life. So it is also involving the lumbosacral plexus here, the nerves which are originating for the lower lumbar plexus and especially the lumbar plexus. So when this will be involved, the pain will be referred to the hip joint, to the thigh, and to the knee joint. So it is the involvement of the nerves in the lumbar plexus. And abscess, this can come into the inguinal region, inferior to the or superior to the inguinal ligament, and it can be mistaken for the inguinal hernia or femoral hernia. Why? Because if you have seen the diagram below, then you will understand why it can. Here, if below this inguinal ligament it comes down, so it can resemble with the femoral hernia or inguinal hernia. It can resemble swelling. The swelling of the abscess can resemble. And when you take a radiograph, the lateral border will be visible, and that abscess shadow can also be visible. It is a case of a psoas abscess on the right side. You can see the vertebral column. It may be because of tuberculosis of the vertebral column. So swelling here is felt in the lumbar region posteriorly. So here in the X-ray it is shown that these vertebrae, you can see, they are not normal. Their bodies are uh, eaten down, or they have degenerated the bodies of the vertebra. So that can be because of tuberculosis of these vertebrae, which will form pus over the iliacus psoas muscle. So when the patient will present, it will present pain in the back, swelling in the back, or swelling in the anteriorly, and then pain refers to the hip joint, or the knee joint, or to the thigh. So here in the schematic diagram has been shown the region of psoas muscle, insertion of psoas muscle. Tuberculosis is the most common cause, and the Crohn's disease of the small intestine, ileum disease, is the second common cause. So this, it can enter the fascial tube of psoas major and track into the thigh, into the femoral triangle. So here it will involve the lumbosacral plexus also. So the pain will be referred to the hip joint and to the anterior of thigh and to the knee joint. Next is a quadriceps paralysis. Quadriceps means quadriceps muscles. Quadri means four muscles. Four muscles we know, and in the interior of thigh, the four muscles are the rectus femoris, vastus lateralis, vastus intermedius, and vastus medialis muscle. They are covering the anterior side of the thigh. So when they will be paralyzed because of nerve damage or because of damage to the vertebral column involving the lumbosacral plexus, so because of the some disease process, so there will be paralysis, that the movement of these quadriceps muscle is lost. So when these muscle will be paralyzed, so because we know that the quadriceps muscles are the strong extensor of the knee joint, so the patient will be unable to extend the knee against the resistance. Extend the leg. Here one hand is over the foot and other hand over the thigh, and the patient is asked to extend the leg, so he will be unable to extend it, and this can be felt. The weakness of vastus medialis and lateralis only resulting from the arthritis or trauma to the knee joint can result in abnormal patellar movement, loss of joint stability, but it is related only to the vastus medialis and lateralis, which are around the knee joint. Otherwise, the quadriceps paralysis will be loss of extension of the leg, extension of the knee joint. So that will lead to a specific gait that is named as quadriceps gait. And when the weakness, the body collapse, hence the trunk goes for anterior bending to compensate it, to shift the vertical vector anterior to the knee balance. Because the quadriceps they are paralyzed, so body will bend forward to compensate this, to shift the vertical vector anterior to the knee balance. Here we can see. And then this gait, what will develop, it will be called as quadriceps gait. And to stabilize the knee joint, very often it is seen that the patient puts his effective hand on that side over the knee to extend the knee joint passively or actively. Here we see the patient is putting hand over the knee, anterior side of the lower end of the thigh and the knee joint, and then pushing backward with the hand, and a lateral rotation of the that to walk normally. So it is anterior trunk bending which happen after the damage to the quadriceps muscle. And this, the gait thus developed, it is called as uh, quadriceps gait. You may have seen in your life the patient walking with their hands over the knee joint and limping and with the trunk bended forward and walking, especially some of the beggars you may see, you might have seen in the streets walking in this way. So that is the quadriceps gait. Next is the patellar bone is very important, although this is a sesamoid bone in the anterior side of the thigh. But for the walking mechanism, it is very important because the damage to this bone will cause the pain in the knee joint and will disturb the walking mechanism. So very first thing is the chondromalacia patella, runner's knee, because this chondromalacia means the damage to the, here you can see the damage to the lining of the inside the uh, patella, and when it will move it will produce friction and there will be severe pain and it will hinder with the running and walking. So that's why it is called as the runner's knee, chondromalacia patella. This is due to the deficiency of the, that may be due to the repeated trauma or to the deficiency of calcium and which are forming the bone and other factors. So here you see that the normal one, here is the normal one, and here is the abnormal one, where the patella is striking against the condyles of the femur, and because of repeated trauma, there is damage to the articular surface, and that will cause pain. So the person will be unable to run. So that's called as a runner's knee. This is basically related to the patella, posterior surface of patella. It's an abnormal softening under the kneecap. That the patella is also called the kneecap. The symptoms are vague discomfort inner of the knee, and it is aggravated by activity running, jumping, climbing, or descending stairs. By prolonged with knee in a moderately bent position, patient frequently have abnormal patellar tracking towards the lateral side of the femur. So fracture can also occur in this patellar bone. So these are called the kneecap fractures, patellar fractures. There you can see. And the fractures can occur in four types. There may be undisplayed simple fracture. Here, there may be transverse so fracture means that the two ends they are away from each other. lower tip of the where the origin of the patellar ligament, that the lower or upper pole that can be damaged. Combined means that it is divided into different parts. And vertical fracture, here is the vertical. This was the horizontal and this is vertical fracture. So these are the 5 types of fractures that can occur in the patella. So signs will be, there will be pain by movement, muscle will be guarded with the passive movement, and decreased function of the part, swelling, deformity, abnormal movement, shape, localized tenderness at the site, because here it is again associated with the quadriceps muscles. The function of the quadriceps muscle will be impaired because it is the quadriceps muscle, they produce their action through attachment with the patella. Now the treatment is sometimes conservative and sometimes surgical. Here are different treatments are given: tension banding, cannulated leg screws, um, Himawari method of comminuted patellar fracture, patellectomy, total patellectomy. So these are the different options. These are only for your interest that I have given this slide. Otherwise, you need not to memorize or you need not to know all these treatment options. What you must know that the because of the problem with the patella, fracture of the patella, the movements they are disturbed, and basically it is through the quadriceps muscle, and you should have a little bit knowledge of this types of the patellar fractures. So the very first thing, very common thing that we see when we go to the clinics of the neurophysicians, or when we are having examination of the nervous system of the spinal cord level, at the level of lumbar spine, to check the lumbar plexus, is the reflex action. As in the upper limb, we have seen we are producing reflex action of the for the biceps, for the triceps, and this is produced in this way, having a soft hammer which you strike against the tendon and the muscle that contracts reflexly. So here the doctor has striken against the patellar ligament, and in this way, actually, it has stimulated the quadriceps muscle, and it means that you should not sit before the patient for the knee-jerk reflex action. You should, the doctor should sit on the side. Otherwise, this thing will happen. So here is shown the mechanism. Reflex hammer is striking against the patellar ligament, patellar tendon, and then it is transmitted to the quadriceps, femoris, biceps femoris, muscle flexor, and these are the extensors. So through this muscle stretch receptors, they are stimulated, they are taken to the spinal cord. Here the cell bodies, and here are the interneurons. Through this interneuron, they are attached back to the. So the information is coming in this yellow line. Here is the interneuron. Then through this interneurons, impulse is given to the motor part, which travels back to the hamstring part of muscles, as well as the quadriceps muscle, and reflex twitching or reflex action, these muscles are contracted. So here is the level is on the spinal cord level. It's not the it is not here the neuron is involved. Here is no neuron is involved, interneuron. So it is at the spinal cord level. It has nothing to do with the upper uh, uh, part of the nervous system, that is the brain. So reflex action is basically located at the spinal cord level. It can be modified by the neurons coming from the brain. So which are basically actually inhibitory one. When the upper motor neuron they are lost, So this reflex become exaggerated because of loss of inhibitory action by the upper neurons coming from the brain. So it is a very important reflexation done mostly by the physicians to check the integrity of the lumbar spine. If they are exaggerated, means there is upper motor neuron lesion, and if this action is absent, reflex action, so it means the problem is here at the lower motor neuron. There is no reflex action, means problem is at the lower motor neurons. Then you see here is the gracilis. So gracilis, now recall in your mind the origin, insertion, and action of the gracilis. It is included into the adductor compartment of the muscles of the thigh, and it's a short muscle, means it's not a big bulky muscle, it's a strap-like muscle. So this muscle, which is a weak adductor and a weak rotator of the thigh and knee, it is not so functionally. Other muscles are present which can compensate it. So the muscles, gracilis muscles, can be taken. Here you can see this is the gracilis muscle on the medial side of the thigh. Along with that is the adductor magnus muscle, which is strong, very strong. Here is the gracilis, here is the adductor magnus, very strong adductor of the thigh. So this muscle can be taken without impairing the adductor function of the thigh, and this muscle can be used. Obviously, this will be taken with this blood supply, and this can be used to replace the deltoid reconstruction, elbow flexion, elbow extension, finger flexion, and finger extension. Here they can be used. This muscle can be used. Also here you can see this muscle is placed over the to replace the masseter action of the mouth, or to reconstruction of the facial surgery. Here gracilis muscle is used. Other muscle which can be used are the radial one. Is the radial artery is taken to replace it, and here is the gracilis muscle. Now is the so what we learn is that the gracilis muscle itself can be used as a graft. You can free the gracilis muscle and you can graft it for the reconstruction of it, for the functional purpose and for the cosmetic reasons over the face. Groin strain, adductor muscle strain. That's why it is called as groin pull. What is it? A strain, a stretch or tear of a muscle or tendon, and it is called as such an injury pulled muscle. The muscle is in your groin, helps bring your legs together. And there are two muscles that may commonly be get injured in the groin strain, adductor magnus and sartorius. So these muscles, when they are injured, your legs cannot be pulled together closer. So that's why it is called as groin pull. The two muscles are involved, adductor magnus and sartorius. Groin pull occur in one or more of the adductor muscles of the inner thigh, gracilis, adductor longus, adductor magnus, adductor brevis, and pectineus. Anyone can involve. And along with that is a sartorius, which can be involved, which is not a adductor, rather it is an abductor, but it can be effective in the groin pull. Okay, so that's and here I've shown you this is more concerned with the physiotherapy department, but You can also understand here an exercise to safely strengthen your adductors. Here is the exercise to strengthen the adductors. When you have a groin pull or adductor muscle strain, this exercise should be used to strengthen them. Femoral line, we have seen studied the femoral triangle, and in the femoral triangle, we know that in the content of the femoral triangle are the femoral artery, vein, and femoral canal. And here in this region, we can locate the femoral vein, and it can be used for the cannulation for the placement of the central line. Central line, that means it will move directly into the inferior vena cava through this femoral vein, from the femoral vein into the external iliac vein, then into the common iliac vein, then into the inferior vena cava. And that inferior vena cava, through that inferior vena cava, you can ascend up to the right atrium of the heart. So that's the femoral. Other sides of the central line, there is subclavian artery or the internal jugular vein, a subclavian vein or the internal jugular vein, which are used for the placement of the central line, and those are located in the neck region. If you cannot use those lines, you can use the femoral vein for placement of central line. Here you see how to locate that femoral this is for the femoral artery cannulation. Here you can see how to locate. Here is femoral triangle. Here is the femoral artery. If you place your little finger over the anterior spherical spine and your thumb over the pubic tubercle, and you place your hand in this position, so it is this one. Here is the artery, this one. Here will be the femoral artery, and you can feel the pulse of the artery here also, and from this point you can go into the artery, and medial to the artery is the vein. Cannulation of femoral artery is done for the angiography purposes very often. For the cardiac angiography, a long catheter is passed through the femoral artery and goes up to the region of aorta, where the coronary artery, they are getting region from the aortic sinuses, and then there the dye is injected, and then this catheter can also move into the left ventricle, and by injecting the dye we can take the photograph or make the movie, and in this way the coronary angiography is done. So here we see cannulation of the femoral artery for the coronary angiography, inserting percutaneously. That's why it is called as percutaneous coronary angiography. So insertion of catheter sheath and dilator along with the guide wire. Here you can see they are placing into the, and this can be done by locating the site of femoral artery in the femoral triangle. Here is some misnomer that is given into the KLM, that in the clinical staff and some vascular laboratories, there is a textbooks which use the term superficial femoral vein, referring to the femoral vein before it is joined the accompanying vein of the deep artery of the thigh, deep femoral vein. So primary care physician may not have taught or may not realize that so-called superficial femoral vein is actually a deep vein, and that acute thrombosis of this vessel is potentially life-threatening. So this misnomer of superficial femoral vein should not be used, because if there is damage to this superficial vein, that can be potentially life-threatening, Actually, it is a deep femoral vein, and thrombosis in this vein can be potentially dangerous. So this misnomer should be avoided. Pulmonary embolism, they originate in the deep veins, not the superficial ones. So we ignore the superficial ones and care for the deep. Actually, what we are naming the superficial is actually is the deep one. Um, then this risk can be reduced by the anticoagulant. Cephalorhynx, cephalorhynx, varicose. This word is from the varicose veins. Here is a saphenous vein. You can appreciate the swelling here. There is the saphenous which is 4 centimeter below and lateral to the pubic tubercle. Saphenous is actually dilatation of the top of the long saphenous vein, great saphenous vein, due to the valvular incompetence. And here, where it is joining the deep femoral vein, soft, compressible. Obviously, it is filled with the venous blood, and when you will lie down, this will disappear. And expansile cuff reflexes there also. So, in every respect, if we see it can resemble with the femoral hernia or the inguinal hernia, because these properties are also of the hernia, because the hernias, they are also soft, compressible, they disappear on lying down on the bed, and there is a cuff impulse, but the fluid thrill is not common in the hernias, that is specific to the saphenous. So we have to differentiate between the saphenous and the hernias also. Now is the femoral hernia, groin swelling. Femoral hernia, you can see here the anatomy of the femoral sheath has been shown here. Femoral sheath having most laterally the artery vein, then there is the femoral canal. So to understand the femoral hernia, anatomy of the femoral canal is very important to be understood. Space just medial to the vein is the femoral canal. Fat and nodes are there, lymphatic nodes are there. So the wall of femoral hernia will be formed by vein laterally, ligament anteriorly, pelvic bone covered by the iliopectineal ligament posteriorly, and the lacunar ligament, which is very important, are Gimbernets medially. It's located medially. Actually, it is an extension of the inguinal ligament over the pectineal line. Lacunar ligament, because it resembles like a lacuna, a moon-like, that's why it is called as lacunar ligament. So the anatomy of the femoral canal is very important for us to learn before we understand the femoral hernia. How this hernia then occurs is shown here, that here is a loop of small intestine. It is entering to the inner opening of the femoral canal, which is connecting to the anterior internal abdominal wall, and through here this loop of small intestine is running down into the femoral canal and is coming out at the lower end of the femoral canal in the region of saphenous opening. Saphenous opening. So then it will produce swelling here. And you can see that how small it is when it comes out, how difficult for these contents to go back into the abdomen. So whenever this hernia will occur, there are more chances of the strangulation of the hernia, femoral hernia. So here is the mechanism of femoral hernia. So in the exam, you may be given a scenario of the femoral hernia, and then you may be asked about the saphenous, or you may be asked about the boundaries of the femoral canal. You may be asked about the normal anatomy of the femoral canal, normal boundaries of the femoral canal. Here you can very well see. Here is a more sophisticated diagram, which is here is another diagram which is showing the two hernias. One is in the inguinal region, and one is over the pubic from the femoral canal. So if you see this hernia, this is below the pubic tubercle. If you and this, if you see this sac of this hernia, this is above this one. This is sac of indirect inguinal, and this is sac of femoral hernia. So it is behind the inguinal ligament. It is over the. It runs over the. It is through the defect in the inguinal canal in the superficial inguinal ring. So coming from the deep inguinal ring to the superficial inguinal ring is the internal opening, is the external opening. So here you can appreciate the difference between the inguinal as well as femoral hernia. This is very important to differentiate between the two hernias because the treatment of the two hernias is different and chances of strangulations are more in the femoral hernia than in the inguinal hernia. This diagram here I have shown you one of the artists is marvelous. You can have many of this if you go to the YouTube or you go to the Google Play and 3D Anatomy. You can find this artist drawing all these diagrams within minutes. And now this explains us very well how the hernia is going to take place. So here is shown the hernia through the great saphenous vein opening. Okay, now are the trochanteric, ischial bursitis, psoas bursa, hamstring strain. So we will discuss these things in the inshallah in the next lecture, and inshallah then we will complete our the. Although the clinicals are very short, I have formed these slides in such a way that you should have a better understanding of these things. Actually, to understand it. So inshallah we will continue next time, and Allah Hafiz. See you inshallah.